Okay, hello everyone. I'm Tangzhou Chen from the University of Manchester, and thank you for giving me this opportunity to present the work about opioid prescribing in Taiwan. And this study aimed to identify the long-term trajectory of chronic opioid prescribing for patients with non-cancer pain in Taiwan when including tramadol. And as you may know that opioid prescribing for chronic non-cancer pain is highly restricted in Taiwan, but tramadol is not included in the regulation about chronic prescribing. So it could be a substitute of other opioid. However, currently there's no study to identify the chronic opioid prescribing and its long-term trajectory in Taiwan when considering tramadol. So our study used the Taiwan National Health Insurance Claim Record to follow opioid user from opioid initiation. And we define every 90 days as a patient quarter and quantify the number of days supplied with opioid within every patient quarter. And patient will be identified as a chronic opioid user receiving opioid or didn't receive opioid in each patient quarter. In addition, we also identify any psychotropics such as benzodiazepine and antidepressant in each patient quarter. For patients who are chronic opioid users in the first patient quarter, we apply group-based trajectory model to identify their long-term trajectory. In addition, we also use logistic regression to identify any association between chronic opioid prescribing and patient characteristics. So overall, we identified 2.3 million opioid users, and about 25% of them are chronic opioid users in the first patient quarter. However, once removed tramadol, only 20% of them still remain as chronic opioid users. In addition, for patients who are chronic opioid users in the first patient quarter, the group-based trajectory model shows that about 13% of them are categorized within this group about long-term chronic opioid prescribing, i.e. those patients who are chronic opioid users in each patient quarter over 2 years. And in addition, regarding their psychotropic prescribing, more than half of them are receiving any psychotropics such as benzodiazepine in each patient quarter. We find several characteristics related to these kinds of long-term chronic opioid prescribing. And one characteristic I would like to highlight is the substance abuse disorder. For patients who have substance abuse disorder history before opioid initiation, they are more likely to be categorized within this group of chronic opioid prescribing. So in conclusion, our study showed that tramadol dominates other opioids to be prescribed for patients with non-cancer pain in Taiwan, and half of long-term chronic opioid users are also prescribed other psychotropics. So this raises the issue about poor pain management and also the safety concern. In addition, for patients who have history of substance abuse disorder, once considering tramadol, they are more likely to become long-term chronic opioid users. So this needs a further evaluation about the potential risk of abuse of tramadol in Taiwan. So this is my presentation, and I'm happy to take any questions.
Okay, thank you very much. And the time is spot on. So I didn't really mention, so everybody will have 3 minutes for the poster presentation, but I'm lucky because your time taking is very well, so I don't really have any issue here. So let me see if there is any question from the audience. Okay, in that case, I will ask the question. So you have the results for sort of like the opioid prescribing there. Were you surprised with your results? Or is it something that you expected to see in Taiwan in particular?
This is something we are expected. It's because before we conduct this study, we already to explore the annual opioid prescribing in Taiwan. And As in our previous study, we already found that the prescribing of tramadol increased almost 100 times from 2000 to 2009 to 2016 in Taiwan. And most of them are prescribed for patients with non-cancer pain. So that is something what we expected to see.
Okay, so do we have any more questions from the floor? If no, then thank you very much.
Yeah, thank you.
So we have the next presenter with the abstract title, Active Surveillance of Hemovigilance in a Tertiary Care Teaching Hospital in a Developing Country Scenario. So it looks like the presenter is not here.
No, I don't see them online. So I guess we can
Right.
move to the next one.
It's the third. I thought the third one is from the same presenter as well. The third.
Yes, that's what it looks like.
Right. Okay. And we move on to the fourth one with the abstract title, The Risks of Serious Infection in Rheumatoid Arthritis Patient Receiving Tocilizumab compared with TNF inhibitor in Korea. You're on mute.
Yeah, I'm a presenter.
Okay.
Yeah.
So you could share your screen and make yourself comfortable.
Can you see my poster?
Yep.
Okay.
So you have 3 minutes.
Okay.
Just start when you're ready.
Yeah. Okay. Hi, I am Havin Jung from Sungkyunkwan University in South Korea. Thank you for giving me an opportunity to introduce myself, my study. The topic of my presentation is the risk of serious infection in rheumatoid arthritis patients receiving tocilizumab compared with TNF inhibitor in Korea. Tocilizumab has been increasingly used for rheumatoid arthritis due to its good efficacy, but some studies found that tocilizumab was associated with an increased risk of serious infections. Moreover, there is limited data on the risk of serious infections among the Korean population, although the pattern of incidence of serious infection in Korea may be different from that in Europe or the US. Therefore, we conducted a retrospective cohort study to ascertain the risk of serious infection associated with tocilizumab versus TNF inhibitor among rheumatoid arthritis patients using the National Health Insurance Database. We included patients over 18 years of age with rheumatoid arthritis who initiated tocilizumab or TNF inhibitor between January 2013 and June 2018. The primary outcome was any infections with intravenous antimicrobial therapy or hospitalization, and secondary outcomes were organ-specific serious infections. To control for confounding, we applied the IPTW using propensity score. Hazard ratios with 95% confidence intervals were estimated using multivariable Cox regression model. We also included some variables in the adjustment model because these variables were considered as potent confounders. After applying patient selection criteria, 1,395 tocilizumab users and 7,399 tocilizumab inhibitor users remained. As shown in table 1, all the baseline covariates were well-balanced after IPTW. The main results are described in table 2. No increased risk of overall serious infection was observed in tocilizumab versus TNF inhibitors. Regarding the infections by organ class, Tocilizumab was associated with a higher risk of skin and subcutaneous tissue infections and a lower risk of urological and gynecological infections. The result of subgroup analysis were presented in a forest plot. Except for sex, we did not find an increased risk in the subgroups. In conclusion, tocilizumab was not associated with a higher risk of serious infection than TNF inhibitor. However, tocilizumab should be carefully used for patients at high risk for skin-related infections. Thank you for your attention.
Okay, thank you very much. So do we have any questions from the floor?
Oh, hello, this is Edward. Can you hear me?
Yeah,
Yep.
I can hear you.
Thank you very much for a very nice presentation. I'm just wondering that is there any, any way to control the different severities in terms of the rheumatoid arthritis between two groups? I may also associate with the outcomes you are interested in. Did you get what I mean?
Oh, yeah, okay.
The severity of the RA.
Yeah,
Is there any
understand.
difference between two groups?
No. As you mentioned, the rheumatoid arthritis severity of the disease is a very important issue but important issue to see to compare the outcome, compare the safety of the tocilizumab, but unfortunately we cannot see the severity such as DAS 28 or like clinical index, but we just included incident new users, so we think that the previous so the severity will be similar between two groups because they were all instant new biologic users, and we excluded biologic prevalent users, and we also see the variable, the number of different conventional demand before during the assessment period. So this kind of we think so. This kind of what should I say?
I think you answered the question already. So the first bit is that from your poster, you can see the characteristics were balanced quite well. But in terms of the issue of severity, I guess similar to your old claims database, it's quite difficult to measure something like that. And perhaps you may consider to add something like the number of hospital visit related to rheumatoid or specialist visit, if that is available.
So we use the proxy indicator.
Yeah, you can use those as a proxy to for security thing, I guess.
Yeah, right. Thank you.
Yes, thank you. And have you considered about the history of the of the traditional DMARDs of the patient?
Yeah, we see the number of the different conventional demand.
Okay.
Yeah, and yeah.
Okay, thank you very much.
Thank you.
Thank you.
Okay, thanks a lot. Then let's move to the next presenter with the abstract title, Use of Antipsychotics and Coordinated Inhibitors and the Risks of Fall and Fractures.
Hello, can you hear me?
Yep, I can hear you. You
Okay,
can share your screen and get yourself ready.
okay. Can you see my poster?
Yep.
Okay, so hello everyone, my name is Grace from National Cheng Kung University in Taiwan. And the topic of our poster is use of antipsychotics and cholinesterase inhibitors and the risk of falls and fractures, which is a self-controlled case series. So cholinesterase inhibitors and antipsychotics are widely used in elderly patients with dementia. While they have both been reported to increase the risk of falls and fractures, confounding by indication should be taken into consideration. So our study aimed to evaluate the risk of falls and fractures in elderly patients receiving both drugs due to dementia. Specifically, we assessed the risk during the period before treatments. So our study population included new drug users with instant falls or fractures, and we excluded those aged less than 65 years and those with underlying schizophrenia or bipolar disorder. And to fulfill the assumption of self-controlled case series, we only identify the first fall or fracture of each person. And we classify the observation period into 5 discrete periods. The 14-day pre-exposure period prior to the first prescription of antipsychotics or cholinesterase inhibitors, and the exposure periods to cholinesterase inhibitors alone, to antipsychotics alone, and to combination therapy. The non-exposure period referred to the time when neither drug was given, and if the prescription was refilled within 14 days after the end of the last prescription, it was considered as a continuous drug use. That is, we included a 14-day grace period in our study. So the incidence rate ratios and the 95% confidence intervals using the non-exposure period as the reference were presented in our table. As you can, and we also adjusted the results by the patient's age. And as you can see, the exposure to cholinesterase inhibitors and to antipsychotics were both associated with a higher risk of falls and fractures. However, since the 14-day pre-exposure period was associated with an exceptionally higher risk of falls and fractures, it seems that patients may have already been at high risk prior to receiving the treatment. So the observed risk during the exposure period may be due to the disease progression in addition to the medication use. So we concluded that the risk of falls and fractures was the highest prior to the initiation of cholinesterase inhibitors or antipsychotics, suggesting that factors other than the treatments, such as disease severity and progression, should be considered while evaluating this association. For more information, please scan this QR code, and thank you very much for your attention.
Okay, thank you very much. So do we have any questions from the floor? So I have a conflict of interest to declare I'm the co-author of this particular study, but I do have a question for you. So you used the self-control case series study design to investigate this particular research question. What do you think is the advantage of this research study design compared to, let's say, traditional cohort study?
So the question is about the reason why we use the self-controlled case series instead of the traditional cohort study. So for the traditional cohort study, we aim to understand the risk among different people, but for the self-controlled case series, since we only selected cases with both the exposures and outcomes. So we aim to focus on the time when patients are more likely to have risk instead of the patients who are more likely to have the risk. So by using this method, we can control the time constant confounders such as sex and genetic factors. And we can focus more on the time period so that we can focus on the exposure period compared with the non-exposure period. And we also specify the pre-exposure period. Yeah.
So one extra question that is that, so in this particular study, you find the risk of your outcome is particularly high in the pre-exposure period, which are not commonly something that you could observe in the cohort study, because we usually start the observation period in the cohort with the start of the treatment. So what do you think this finding could mean to clinicians and patients?
So the question is about the reason why the pre-exposure period has a higher risk, right?
Not really why, but what does it mean to clinicians and patients?
Okay, so since the objective of our study was to address the confounding by indication, so we specify the pre-exposure period. And the hypothesis was that during the pre-exposure period, patients may be under more severe conditions. So for example, they may have very much cognitive impairment or suffer from agitation or psychosis. And those conditions make them have to use the antipsychotics and cholinesterase inhibitors. So, so we can see that during that period, the risk of falls and fractures was exceptionally high. And after they use the medications to control their symptoms, the risks actually reduced from the pre-exposure period. And even though they did not reduce to the baseline, it's still, I think the medications are still useful for these patients. So we can inform the clinicians that if the patients are very unstable, such as they're very agitated or very psychotic, and it's better for us to prescribe the medications instead of not prescribing them due to the side effects.
Okay, thank you very much.
I have one question.
Yeah, please go ahead.
I'm Soy Park from Sungkyunkwan University. Question is about the case SCCS design. As shown in your results, the incidence rate is not rare. Your outcome of events seems like not a rare events. Could you say your outcome of interest are independent within individuals?
So are you asking about why we only identify the first outcome of events of each person?
Yes.
Okay, so for the self-controlled case series study design, the outcome is supposed to be independent among different periods. So if we ignore the exposure and the non-exposure, we just look at the time periods, the outcome of interest should be independent. However, the falls and fractures are not independent. So if patients have the first fall, and it's more likely for them to have the recurrent fall or fracture. So due to this reason, we only identify the first fall or fracture.
Thank you.
Yeah.
So are there any more questions from the floor? If no, then thank you very much, Grace.
Thank you.
So the next speaker with the abstract title, "The Risk of Seizures Associated with the Use of Tramadol, a Nationwide Case Time Control Study."
I'm a presenter.
Yeah, I can see your poster up and ready. So when you're ready, just start, please.
Let's start. Good morning. My name is Soy Park, a PhD student from Sungkyunkwan University in South Korea. My topic is the risk of seizures associated with the use of tramadol. Tramadol is a commonly used analgesic, but there is a concern of seizure with its use. Warning of seizure risk was placed on the package insert of tramadol in the 90s based on spontaneous adverse event reports during post-market surveillance and the potential to trigger seizures with its mechanism of action. However, the evidence was inconclusive in real-world practice. Hence, we evaluated whether transient use of tramadol is associated with an increased risk of seizures in patients with non-cancer pain. We performed a case-case time control study using a 14-year of national sample cohort database from South Korea's claims data. Each case identified by seizure event was matched for age and sex to one future case to adjust for exposure time trend without selection bias from the use of an external control group. As shown in the figure, the number 1, the use of tramadol was assessed in 3 periods preceding the incident seizures, 1 risk period and 2 reference periods. We performed crossover analysis using a conditional logistic regression model to estimate the odds ratio for the association between seizure risk and exposure to tramadol in each of the cases and future case controls. And then we calculated case-case time controlled ratio by dividing the odds ratio in cases, that is, case crossover odds ratio by the odds ratio in future case controls, that is, control crossover odds ratio. We performed several subgroup and sensitivity analysis. Let's move on to the following stage results. We identified 2,900 incident seizure cases from the 1 million people and 2,500 matched with future cases. As shown in the table, the number 3, increased risk of seizures was observed in both case crossover analysis with odds ratio of 1.19 and control crossover analysis with odds ratio of 1.27. However, in the case-case time control analysis, the use of tramadol was not associated with the seizure risk. Odds ratio was 0.94. In conclusion, findings from this study with case-only design suggest that the use of tramadol appeared to be least associated with the risk of seizures in clinical practice, despite concerns on seizure threshold lowering potential of tramadol. But interpretation of our findings from concomitant use of other seizure threshold lowering drugs like antidepressants or opioids was limited due to the small size of this subpopulation. And the evidence on when patients use tramadol in the long term or abuse is still inconclusive. Further studies are needed to answer these clinical questions. Thank you. Any questions?
Thank you very much. Any questions on the floor? If not, then I have a question that, so this is the case time control is sort of like the evolution form of the classical case crossover, in which the case crossover is only one major assumption that is about the exposure time trend. So in tackling the exposure time trend, there are actually 2 options. One is what you have presented is the case time control. The other one is the case time control. So clearly you choose the case time control approach over the case time control. Do you have the rationale why you pick the current design over the case time control setting?
We try to apply the case time control approach, but defining the external control group is too difficult to reverse design. So we applied the case time control design. It's more easy.
Okay. Do we have any more questions from the floor?
This is Edward.
Yeah.
Can you hear me?
Please.
Okay. Thank you very much for a nice presentation. I'm also interested in the case time control approach. In your result, it shows that the future case control also have like increased risk about like a 1.27, and also which is significant. Is there any like explanation for this result?
There were several implications, but we don't have information about this yet. We only investigate the exposure time trend, and their time trend exists, and we don't have information about expanded that yet.
Okay. Yeah, just wondering if this is possible about case time control to adjust the exposure trends, especially for individual level. So is that possible? Like a person who use the tramadol may have like a individual trend in terms of the using, in terms of the outcome. Do you get what I mean?
Sorry, I didn't catch all of that. Could you repeat your question, please?
Okay, I mean that case time control, which is aimed for adjust the individual level exposure trends, right?
Yeah.
So is there any like a possible explanation that we can observe the significant difference for the future case control because of the individual trend of the exposure?
But I think the future case control represent the exposure time trend, not in the individual level, but possible exposure time trends. Oh, is it the total answer for your question?
Oh yes, because just try to discuss if there any like a possible explanation. Actually, I don't have any ideas either.
I think that's the trickiest point is that you consider your so-called control group, which is your future cases, and the adjusted odds ratio that there is significant effects there, compare with your current cases, which there is no significant effect already in your original analysis. That's if you solely use a case crossover setting, there's actually no increased risk in your original cases as well. But then interestingly, if you push back the exposure window a little bit for the cases, there's an increased odds of having the exposure in the previous time rather than the time around your outcome of interest. And that's what the results told me actually. Well, that's an interesting scenario, but I don't think I could have the explanation out of my head at the moment. But as Edward said, worthwhile to have further discussion on this interesting scenario.
Can I ask a question?
Yeah, sure, go ahead.
Because from my experience of applying the UK data, the incidence of seizure in tramadol user is quite low. So I wonder, because finally your research reached about 2,500 cases. So I wonder, have you done any power calculation about your result to see why these kinds of study design that haven't show a significant association?
Are you asking about whether we do power calculation?
Yeah. Yes.
We did not the power calculation, but I appreciate your comment. We did not get the chance to think of this.
Okay, yeah, thank you.
I don't think they need a power calculation actually. If you look at the accrued odds ratio, it's already significant, but just after adjustment with the time varying confining factors. it became non-significant. So intuitively, I don't see this current study without enough sample size to do so. But that's a good one, I guess. Okay, any more questions from the floor? If no, then thank you very much. Let's move on to the next presenter with the abstract title, The Association Between Influenza Vaccination and the Risk of Bell Palsy in the Korean Elderly. I can see your poster, but I cannot hear you.
Yeah, can you see my poster?
Yeah.
Yeah, I'll start the presentation.
Yeah.
Hello, my name is Nayang Jung. I'm a PhD student from Ewha Women's University in Korea. I'm going to briefly present the study about the association between influenza vaccination and the risk of Bell's palsy in the Korean elderly. There were several publications indicating a possible association between influenza vaccination and Bell's palsy. However, it still remains uncertain. This is more important to elderly because most elderly receive flu vaccine in Korea and they are at high risk of Bell's palsy. Therefore, we aim to determine whether there was a risk of Bell's palsy for the elderly after flu vaccination during the 3 flu seasons. For this study, we used linked databases of the KCDC's vaccination registry and the National Health Insurance claims data. We included the influenza vaccine from 2015-16 to 2017-18 flu season who were aged over 65 years. We confirmed the Bell's palsy cases using ICD-10 code and the prescription of glucocorticosteroids. We conducted the self-controlled risk interval design study to compare the risk in a risk period with the risk in a control period. For primary analysis, we set the interval 1 to 42 days and the control interval 57 to 98 days post-vaccination with 14 days washout period between the two intervals. We used other lengths of risk and control intervals for sensitivity analysis too. In addition, we performed subgroup analysis for age group, gender, vaccinated months, and the history of chronic diseases related to Bell's palsy. As we can see in the results section, among the around 4,600,000 vaccinated, we identified 1,348 patients and 1,362 patients within the risk and control intervals each. For primary and sensitivity analysis, there was no significant risk of Bell's palsy. However, in 2017-18 season was statistically high when the length of risk interval was 28 days. We also identified there was statistically significant increase of risk among patients with diabetes or dyslipidemia when the risk interval was 1 to 14 days. There were several limitations in our study, such as the validity and misclassification bias caused by claims data. Also, the data did not include information on the type of influenza vaccine and other vaccination records. Overall, we found no evidence of elevated risk of Bell's palsy after influenza vaccination in Korean elderly. However, given that the formulations change annually, continuous monitoring during future flu seasons is needed. Thank you very much for your time.
Okay, thank you very much. Do we have any questions from the floor? If no, then I will have to ask a question here. So apparently in your primary analysis, none of your analysis have attained the statistically significant results there. But then when you move the risk interval to 1 to 28 days, and then 43 to 70, one season or one batch of the flu vaccine attains the increased risk. Do you have any explanation about that one?
Yeah, thank you for your question. So, yeah, as a for primary analysis and most of sensitivity analysis, we found no evidence of risk of Bell's palsy after flu vaccination. But as you can say the one season indicated that there was statistically significant risk of Bell's palsy after vaccination. So we concluded that, as you can see in the conclusion, the formula of influenza vaccine is very different from every season, and we checked that the 2015-16 season and 16-17 season share some formula, same formula, but 2017 and 18 season did not share the same formula from other season. So it is not clear, but we concluded that the formula of vaccine can affect the result of the study, but we concluded that most of results indicated that there was no risk of Bell's palsy, so there it considered safe to the elderly after the influenza vaccination. So thank you for your question.
Okay. Do we have any more questions from the floor?
This is Edward. Thank you very much for the presentation. Just wondering that is there any information about the validity of the diagnosis code for Bailey palsy?
You mean the validity of Bell's palsy that we use the ICD-10 code and the WATC code?
Yes.
To confirm the cases, we use the ICD-10 code G51.0. It means Bell's palsy, and we use to increase the validity. We also uses the glucocorticosteroids within the 14 days of the diagnosis. For some previous studies in Korea, we used the same data of national claims data. Most of studies use the same ICD-10 code to identify the Bell's palsy cases, and also most of cases use the same WHO ATIS code. So because most previous studies use the same databases, use this case definitions, so we thought that this definition is appropriate to identify the cases. Thank you. But as I also say, as one of the limitation, the validity problem is also remain, I think.
Okay, thank you very much.
Do we have any more questions from the floor? If no, then thank you very much.
Thank you.
So that comes to the end of our section, and I know the time right now in Asia is a little bit bizarre, but thank you very much for everyone's attendance. And I do look forward to the next year that we can meet physically. So thank you very much, everybody, and a nice day, have a nice night, or have a nice afternoon, wherever you are. Thank you.